We're at the IAS meeting in Vancouver, BC. We're here with Mitchell Warren, who's been gracious enough over the years to give us a lot of background information, which is what we like. And Mitchell is with the AVAC organization, and we really appreciate your doing a couple of things today. One, we're going to start with prevention.
Sure.
So, and your big thing is vaccines, but there's a lot of other components that are all partners, and we're all merging all the treatment, prevention, cure, and care all in one big package these days.
Absolutely. You know, this is one of the most exciting times, I think, in AIDS science and AIDS implementation. So obviously we're sitting here in Vancouver in the midst of some of the most remarkable news about antiretrovirals, confirming what we knew, or what we thought we knew, about treatment, both as treatment and treatment as prevention. And that's thrilling. But we also recognize, and I think this meeting really highlights, that that alone isn't enough. And I think there's a really important point that Mike Cohn raised yesterday in presenting 052 that really does identify a huge gap. Treatment, getting viral suppression in the HIV positive part of a discordant couple is incredibly powerful prevention for the linked transmissions, for transmission within that relationship. And there were very few, and we know that those virally suppressed didn't have transmission events. But we also know there were more than 24 infections that were unlinked to the discordant couple. So we know that treatment is critically important for the individual who's infected. We know it's really powerful prevention within that relationship, but we also know that we need more prevention services. And in fact, I think we talked to CROI in February, the really exciting study from Kenya and Uganda, the Partners Demonstration Project, which actually showed that offering treatment to the positive partner and PrEP to the negative partner actually not only prevented the linked transmission, but it actually prevented almost all of the unlinked transmissions too. So it really identifies that. And then we look to the future, and I think the piece that's kind of an undercurrent here is not just the research around the drugs we have, but the power and the possibility of some of the newer approaches with long-acting injectables that are antiretrovirals, really new and interesting vaccine candidates, and the really interesting movements around antibodies for both prevention and maybe treatment and maybe even eradication.
Yeah. So what do you think as far as the long-term injectables? I mean, this seems to be something that we're looking at, and yet we will probably be able to use them maybe by themselves, but more likely with other drugs as well, which may take a little bit of the benefit.
Well, there's
out of the
lot,
picture.
there's a lot of enthusiasm. There's always a desire for the next big thing. You know, the thing we don't have is often the shiniest and most exciting. So I hear a lot of people saying, well, oral PrEP is hard, adherence is an issue, and we're gonna have long-acting injectables. They're around the corner. Well, they're around the corner, but it depends on how far you look around that corner. We currently see the 2 long-acting ARVs in a combination treatment trial, and then both are being studied separately as independent agents for prevention in small phase 2 studies. So we are still not even in the efficacy phase for prevention, and even if it works in those trials, it doesn't reduce and eliminate all the adherence issues. So it's exciting, and it's important that we follow that science. And I'm incredibly excited by the possibility, but there's a lot of uncertainty.
The different applications that could be construed can be viewed out of that. There are a lot of places where you don't want to have to be doing daily treatment. Or traveling and so forth. So
absolutely,
this is important.
It has huge promise, and again, what's exciting for me, also a little bit of, for me, what's interesting is that the industry's involved. One of the challenges we've seen with vaccines and with microbicides historically is limited pharmaceutical engagement. And what's interesting about the long-acting ARVs is because they're being developed for treatment directly by Janssen and by ViiV GSK, they are much more engaged in the prevention space. And actually, it's one of the things we don't talk about so much because it's a scientific meeting, but it's similar in the vaccine world now, where industry's beginning to get much more involved. So one of the most exciting new events was actually just before this conference, a publication in Science that looked at the animal studies with an adeno 26 vaccine, and Dan Baruch at Beth Israel in Boston led the study, but working very closely with now Janssen in their vaccine division. And they're now, Janssen themselves are running a large phase 1-2 trial that, if successful, would move into an efficacy trial for their vaccine combination. It's the first time we've seen a company get involved in over a decade. In terms of many companies are involved with their ideas, and they'll happily come along if NIH or the Gates Foundation funds them. But Janssen's putting money on the table in a significant way and advancing this product in their own program. And then you have the two companies looking at these long-acting ARVs. So I think 2015 is a really important turning point, and I reflect on it in part. AVAC started 20 years ago, this year, and our very first report was about getting private industry involved in vaccine research. So it's taken 20 years, but we are now seeing in prevention with antiretrovirals and with vaccines and with even the antibodies, industries coming to the table.
And this blurring of all facets of treatment, prevention, and care is very, very exciting. The other piece that you wanted to bring to it, I know you wanted to talk about briefly, because we already did prepex, but circumcision is...
Well, it really, because this conference has so much important science coming out with antiretrovirals, it's really easy to think of both, antiretrovirals for treatment and for prevention, and we should, and we need to be very clear, and I think, we know WHO guidelines are coming out, but as Ambassador Debbie Birx, who leads PEPFAR, said yesterday, don't wait for the paper, don't wait for the glossy brochure. We know what to do. We know that we should be offering treatment, so offer treatment to anybody upon diagnosis, and we should be offering oral PrEP to anyone at high risk. We know those things are true scientifically. We have guidelines forthcoming. We need to do that. And that was very much the heart of the Vancouver Consensus, which was signed by scientists, policymakers, activists, really saying we should be doing both of these things with antiretrovirals. And it's a great consensus, but it's not a complete consensus. And the reason it's not complete is we know that antiretrovirals alone cannot end this epidemic. Even with treatment scale-up, even with PrEP, even with long-acting ARVs, we need other things. And I think for me, one of the most important anniversaries sitting here in July 2015 is the third IAS meeting, pathogenesis meeting, which took place in Rio de Janeiro, another very beautiful city, in 2005. And there, the most important scientific finding presented was the Orange Farm study of circumcision, which showed, without a shadow of a doubt, over 60% protection. And then a year later, we had 2 more trials confirm that. This is a remarkable intervention, incredibly cost-effective, whether it's with surgery, whether it is with the new devices. Circumcision can have huge impact. And in that 10-year window, WHO and UNAIDS really put out a 20 million target to get 20 million men in 14 African countries circumcised. Great news. Sitting here today, we're halfway there, 10 million. In that 10-year window. We need 10 million more, but funding's disappearing. So we need to be sure that we embrace the science, and that means embracing the START result. It means embracing HPTN-052. It means embracing Partners PrEP and IPREX, but it also means embracing Orange Farm. And it means that just because it's 10 years old doesn't mean it's old news. Exactly. It is current.
It still works the same way it did.
And it's a one and done procedure.
Yeah,
it is. If we had a vaccine at that level,
yeah.
We would be having a very different conversation.
Yeah.
It's obviously got huge social and cultural issues involved. But I think at the end of the day, what we have, I think, begun to lose a little sight of as we talk about treatment or prevention or vaccines or cure or antibodies, is that this epidemic doesn't end with 90-90-90. It ends with a comprehensive, integrated, and sustained response, which means it has to not only be drugs and circumcision. It has to be about human rights. It has to be about offering people options. It has to be grounded in health systems and political systems that work, that don't criminalize and stigmatize people at risk. And we're not doing that if we just think of this as a pill.
You have mentioned what many people have mentioned, the stigmatization and also the criminalization. It's a huge issue, and we all should mention it over and over again, because it's not going away as quick as we want it to.
I wish, as much as we need new drugs and vaccines for HIV, I wish we had drugs and vaccines for stigma and discrimination. We don't, but we have got to deal with them, because even with the greatest antiretroviral, even with the greatest vaccine strategy, if we don't address those fundamental issues, we do not end this epidemic.
Exactly. Well, Mitchell, on that, I will leave you. We have really appreciated your wisdom and your advice and your offering that you gave today.
Well, I appreciate it. We stand with an opportune moment that we shouldn't let slip away.
It is an opportunity, yes.
Thank you so much.